Good morning, everyone, or hello, everyone, because it's already not the morning anymore in some of the countries that are joining us. I'm very delighted to welcome you for this 30th EMCDDA webinar. It's just incredible to realize that since we organized the first webinar in the beginning of the COVID pandemic, we already managed to organize 30 editions. I think this 30th anniversary is something very important for the agency, for the current agency, and for the future EUDA. I think but there are many reasons, but the main reason for me is that with the EMCDDA webinars, we went one step further towards more co-production, more participative approach with our partners. I would say in the past, not necessarily for bad reasons. It was usually EMCDDA speaking to the world or to Europe, and certainly there are needs and there are moments in which we address the different audiences, the decision makers or practitioners, as EMCDDA talking to the world, but with the evolution of our work, the many partnerships we have with professionals, with practitioners, and also with people with lived experience. I think for me, one of the main features of the EMCDDA webinars is not EMCDDA talking to everyone, is EMCDDA facilitating the exchange of expertise with so many experts from everywhere in Europe and outside Europe, and sharing with our different audiences. So as I said, co-production is really a key for work and will be also at the heart of the customer-centric model for the new EUDA. So we have, I want to thank first the EMCDDA colleagues, including Marika. Usually I am the one calling to the webinar from the airport. This one is the time it's Marika. So thank you, Marika, to be there and for piloting those the preparation of those 30 webinars. I have a special welcome to Janelle Sandberg because today the seminar, the webinar is a webinar that we organized together with our sister agency ECDC, and I want you to convey my best regards to Andrea Hammond, the director. We have a long-time partnership between the two agencies, and this is one more example, and I think we will have more in the future with the mandate of the new agency. And then I cannot avoid, I would not miss the opportunity to welcome Matt, Katri, and Alexander, will be the speakers today, illustrating each of them the point of view from different stakeholders. So as we are just the week of the preparation of the EMCDDA management board, and in 2 days we will be adopting the work program of the new agency. I cannot stay until the end of this webinar today, so please accept my apologies, and I will not come for the conclusions, because how to conclude without listening to the speakers, I think this would be not very useful and certainly not very interesting. So in a few words, why is this topic important for us today? First, because it's one of the joint activities with ECDC, and we have been working on those guidelines, and they come at a very important moment. The second reason is that we have we had, and we will have still at the end of this month, a set of new publications about some of the harm reduction services that are presented and commented in the guidelines. Namely, before Christmas, we will launch the joint publication together with the Correlation Network on drug consumption rooms. And that is a topic that is very important, and it's at the heart of many discussions everywhere in Europe and outside Europe. And I will come back to this point in a minute, but I would like to comment or to insist on one of the characteristics of the guidelines that may not be very familiar to some of the people who are listening to us today or those who will read the guidelines. It's about the grading of the scientific evidence. Grading scientific evidence is at the heart of our work, both for ECDC and for EMCDDA, and certainly for these guidelines. And I think for those who used to read publications of EMCDDA, it may look a bit different from what we publish usually. And I think the reason behind is that when we talk about those topics, the reference is not necessarily the way we usually work in the field of addictions. It's the way we work in the field of public health, infectious diseases, the impact of vaccination campaigns, and there the way to assess the things is and the impact and the efficacy is very well documented. There is a strong methodology. So, and this is the reason why, and we have done the same for the umbrella review of medical use of cannabinoids, and we are going to publish soon the update for this publication. When we explain that there is no strong scientific evidence regarding the efficacy of a method, it doesn't mean that we should not use that method. What it means is that we lack research and we lack strong evidence. The strong evidence means that there is a direct more or less direct causality link between the intervention and an impact at the level of the population. And for instance, certainly while we can see the impact, for instance, of drug consumption rooms for the users, what is a different thing is to pretending that the work and the work and the system, the services from the drug consumption room have also an impact on the broader population of people who are using drugs or a benefit for the entire population. So as drug consumption rooms are really at the center of many discussions, I think it is fair enough to highlight what is meant by strong, weak, or average evidence. That's the first point. The second point is even more important because what we get as information from the field, from the different networks and partners, and also from the colleagues from drug consumption rooms a bit everywhere in Europe, is that in some cases there is not enough support and not enough recognition about how useful it is. But an equally increasing problem and anxiety for some decision makers and practitioners is the fact there are wrong expectations toward drug consumption rooms. In some cases, it can be even worse. And this is why I think what I invite you to do while listening to the speakers today, and when you will read the guidelines and soon the new publication, is really, I think for me, the conclusion for me is relatively clear and simple. Instead of talking only about the impact of or efficacy of services or different kind of services separately, I think in the same way we speak for years about prevention system, I think in the future, starting today, we need to speak about treatment system and harm reduction system. And also, when we do that, not for a topic today, but probably for one of the next webinars, I think when we speak about harm reduction and harm reduction system in the future, we need to include a new harm, a new risk, because here there is a big difference between the French name of harm reduction and the English name. In English, we speak about harm. In French, in many countries, not all of them, we speak about risk. And for me, the right approach and broader approach is risk. And if we look at the risk, today, we need to include the risk associated to drug-related violence. If we want to make a correct analysis of a situation at local level, at field level, it cannot be just discussing about one kind of services or one kind of intervention. We need to keep the holistic approach. We need to keep and collect all the possible available data regarding the different elements. And then on that basis, we build a system. And in that system, you have different elements. And each of those elements have a role to play, but none of those elements on its own is the full solution for the entire situation. And therefore, I think those guidelines that we are jointly publishing with the ECDC, they bring a very good and very strong contribution. Also because that's my last point. The reason for, or one of the main reasons for publishing those guidelines together is that it's not specific to drugs and drug use. It's about also the Millennium Goal and the objective for instance, of eradicating hepatitis C. And again, to eradicate hepatitis C, we need a different set of interventions and services. Harm reductions are part of them. And I think some of the most interesting experiences in the recent years show that the only way to really achieve the Millennium Goal as far as the eradication of Hep C is concerned is to bring together in a different mode than before the drug-related services and the infectious diseases or hepatology or hematology services. And for instance, the Professor Rui Tato Marinho and his team in Lisbon, they did the fantastic initiative, because having prisoners to be sent to the general hospital for testing and then for treatment was always a challenge and was almost impossible to achieve. So they decided to bring the hospital to the prison. And I think this gave incredible result, because they managed to have a total screening, to have the diagnosis of people who were positive, and they managed to achieve the treatment, the full treatment for Hep C of all of them. So this is where we need to join the efforts in the future, and therefore I want to thank again the three speakers and also Janelle and the colleagues of ECDC for this joint opportunity to share scientific evidence and scientific-based evidence regarding how together we need to organize, activate, and multiply those interventions and those responses. Thank you very much.
Thank you very much, Alexis. Perfect introduction to the webinar. And I'll just immediately pass the floor to our chairs, Anne and Janelle. Floor is yours.
Thank you very much, Ale. And good morning, good afternoon to all the participants who have joined in the meanwhile. I will be moderating this webinar with my colleague Janelle Sandberg in ECDC. So before I introduce the speakers with Janelle, I would like to mention that when it comes to questions, we would appreciate if you post the questions in the Q&A box, not in the chat, because in the chat they can easily get lost. So for questions, please put them in the Q&A. That would be great. Thank you so much. And without further ado, I will introduce our first speaker or panelist, Katri Abel-Olla. Katri works as the Estonian National Institute for Health Development in the Center for Drugs and Addictions as a researcher. She's also the head of the Estonian focal point for the EMCDDA. She has been leading on several monitoring and research projects in the field of drug use. Her research areas have included risk behavior studies of people who inject drugs, syringe residue analysis studies, wastewater studies, and web surveys on drug use, as well as of mapping and quality assessment of prevention, harm reduction, addiction treatment, and rehabilitation services. Over the years, Katri has been involved in drafting many strategy documents in the field of drugs and infectious diseases. So very warm welcome to you, Katri. And now I would like to hand over to my colleague Janelle, who will introduce our other panelists today.
Hi, everyone. My name is Janelle Sandberg, and as mentioned previously, I'm joining from the European Centre for Disease Prevention and Control here in Stockholm. And together with EMCDDA, we have developed this joint guidance. I have the great pleasure today of introducing both Matt Southwell and Aquino. And we'll start with Matt. Matt was one of the United Kingdom's first generation of harm reduction workers in the late 1980s, founding a pioneering community-led harm reduction service called the Healthy Options Team. He came out about his own drug use on a BBC TV documentary in 2001. Since this time, he is focused on drug user organizing, currently working as a half-time project executive for the European Network of People Who Use Drugs, and as a managing and technical director of COACT Technical Support Limited. And the next panelist that I would like to introduce is Professor Baldacchino, who is a clinician or psychiatrist, more specifically, working in the field of addiction for the last 30 years, with varied academic research and training interests to help improve the lives of our citizens, which he has been very honored to work with. And with this, I now pass back to Anne to get us started on questions.
Thank you, Janelle. And there's one more just announcement that all EMCDDA webinars are recorded. So a recording will be available on our institutional website, and you're more than welcome to share the recording with your colleagues within your networks and colleagues who were not able to join today. So now I would like to start by asking Katri about what you consider as the main practical implications of this updated joint guidance that was launched by the ECDC and EMCDDA in the last month.
Thank you, Anne. And I have to start maybe a little bit negative way, because I fear that the practical implications of these guidelines at the national levels are unfortunately not very quickly perceived. Not, I think, at least in the nearest future, because I believe, and I really like the document. It's good, it's clear, it's short, and it's very user-friendly, comprehensive, and all the evidence-based and best practice-based pieces are there. But from the other side, of course, there is a strong need for this kind of a wider and updated range of harm reduction services and the better coverage, especially when we talk about countries like Estonia, which have very high infectious disease rate among people who inject drugs. But we have to keep in mind that the primary obstacle is the governmental sector these days, because this sector is responsible for delivering to services and overall framework also. But we know that now more than ever, we have very limited resources on governmental level. And also the way how this level works is, for at least in Estonia, it's long-term planning. And sometimes the national work plans are made and resources allocated, for example, for a 3 years period. And it's not so easy to fit in their new ideas, actually, what are resource demanding, and really sometimes even need to change some restructuring or change some system what we currently have. But to be positive, I think that the guidances actually set a very holistic and good approach. And all the different services and the elements of the services are present there. So it kind of gives this kind of a good whole system. And also what I really like from the document and would be helpful for the service like planners is that it also gives this kind of a wider context how actually those services should be like perceived or in the wider system. And I think that this is good because really the decision-making level should understand that we don't need the bits and pieces of the system, but we really need this kind of a whole system to make it work. And I think that the value is also that the planners actually can understand how complex and multi-level approach is needed to tackle this problem, because the services they are like from very different levels, and the levels should work together to make this happen. But it's really tricky, especially when we consider this kind of vulnerable group as it is our people who inject drugs. So this is, but from that document, if you really read it, you understand how complex this system is and how you really need to tackle this. I don't say it's easy, but it's there. And also, what I like there are terms of multi-component intervention and combined service provision, what really helps to focus on integrating services and kind of gives the hint how to be rational with limited resources. For example, if you want to expand the services, then one way is pharmacy-based services and etc. And the last point for this question is I like the empowerment of prison system there very much, because it's several times mentioned there what kind of services should be also present in prisons. And I generally have believed long time that they are like ideal communities to treat and control infectious diseases, because the target group is there, they are not going anywhere. And of course, when we know about people who inject drugs, then most of them or many of them have spent their time in prison, so it's the perfect place. And it kind of, this document is a kind reminder to people like that prison should be more than just a penal institution, but they really have the possibility to reduce harms in society. Yes, thank you.
Thank you very much, Katri, for sharing your reflections on many of the practical considerations. And I would now like to turn to Matt to ask you whether what Katri shared resonates with you as a representative of the broader community of people who use drugs. You have been integrally involved in the updating process as a member of the ECDC, EMCDDA expert panel, which was established to oversee updating of the guidance. So you're very familiar with it. You've heard from Katri as a policymaker, program planner, government representative. Now, what is the reflection from the community? Look forward to hearing your views about the practical implications of the guidance.
Thanks, Anne. Look, firstly, I want from EuroMPUD's perspective to thank EMCDDA and ECDC for the commitment to meaningful participation and for including people who inject and use drugs in the development of the guidelines themselves. I think that if you read the guidelines, you can see the influence of community voices on that process. I think we should always remember that when we're going back to harm reduction started with people who use drugs. No, the first needle and syringe program was run in 1982 in Rotterdam by the Junkiesbund. It was run in response not to HIV, but actually to hepatitis B. And I think we should remember that much innovation in harm reduction comes from the drug-using community. I think it's very inciting that there's the new global AIDS strategy puts this real focus on community-led responses, and that can be seen in these guidelines as well. I think the challenge of these types of guidelines is that they're properly driven by the hard data. So there's the very scientific process of evaluating what data is out there. The challenge is that many of the community-led models aren't always so well represented in that hard data. And so therefore that storyline, that critical storyline can be invisible. However, I think this combination of using a Delphi study as well, so capturing the voices of experts and in making sure that people who use drugs were part of that expert consultation, has allowed some of the softer data, the softer experience also to be reflected in these new guidelines. And for me, that was a very interesting process to be part of and to understand how that model works and can complement the sort of hard data. It's not an argument against hard data, it's about saying we need to complement it. I think we need to also look at that, the difference between the in principle commitment to community-led responses and then the reality of community-led responses. I mean, we have a global AIDS strategy committing to 60% to 80% of future Hep C prevention, HIV prevention should come from community-led organizations. If we have 1% of funding in Europe going to community-led organizations, I would be surprised. So we have a huge difference between the aspiration for communities to be more involved and the funding that just doesn't come to us. Why doesn't it come to us? Well, there's a lot of different reasons for that, but stigma and discrimination, criminalization, and also professional organizations holding desperately onto hard-won funding. And in a shrinking funding environment, it's very hard to see how we see this substantial transition of funding to community-led organizations. How's that going to take place? That's going to be very challenging if we have to fight our professional partners for their hard-won funding so that we can play a stronger role. But I think that hard conversation needs to take place. No, you can't just say we support community-led involvement, we want communities to be involved, and then not to invest in that process. No, the European Network of People Who Use Drugs operates on 150,000 euros a year to work in 25 countries. I mean, it's just unfeasible to really see us playing a substantial role if we don't have the funding. And the reality is our community-led organization in country, they rely substantially on EuroMPOD to provide them with funding. So it's not like many drug user groups have significant funding in their own right. There's some exceptions, the German network JESS or the wonderful Metzeneris project working with women in Barcelona. Some of them do have funding, but they really are the exception rather than the rule. I think the other thing we need to look at is, look, we're seeing a constant evolution of drug use. No, drug use is never static. So and who tells you about the changes in drug use? It's the community. We're the ones best positioned to talk to you about the changing impact of different drugs, different ways of taking drugs on the ground. And for me, this is not a competition, it's a partnership. It's how do we work collaboratively together to deliver these wonderful new guidelines that so clearly set out the evidence. But we have to have the funding to back that. We also need the legal environment to do the work. We're working constantly in a context where we're criminalized. In my hometown of Bath, we work with local drug suppliers and local drug users to run a peer-to-peer needle and syringe program. We're the one area in the UK that has bucked the trend of reducing needle and syringe coverage during the COVID-19 pandemic because we work with the drug using community to give out needles and syringes. How much funding do we have to run that service? Zero. We get equipment from the local system, but we deliver it on a voluntary basis. We can't even get basic funding to run a peer support program to educate our peers. At the same time, funding is going constantly to providers who aren't delivering always. And I think that becomes a very challenging context of having workers sitting in agencies, often not seeing that many people, while we're out in the community doing the work without resources. And I think that does create ill feeling. And I think we need to start to have greater equity in how money is shared, how work is shared, and how we contribute to each other and support each other in this important work. And just finally, I think the other function that we can really provide, I'm sitting in Budapest at a meeting of the Correlation European Harm Reduction Network, where we're discussing how do we gather data, how do we create the evidence base to effectively assess the response. And the new dynamic we're talking about is how do we gather community-led data? So it's not just harm reduction providers, policymakers giving data, it's also the community itself giving data. So for me, it's collaboration, it's funding, and it's also supporting the key role that community-led organizations play in the response.
Thanks so much, Matt, for very insightful reflections. You brought out so many challenges, but also opportunities in terms of the collaboration that we already have, and we hope to strengthen as we go along. We have the EU drug strategy, which clearly calls for greater collaboration and partnerships with civil society organizations and the people who use drugs. So I think this is really a turning point. I think we have a roadmap, we have the EU Drugs Action Plan, and we look forward to that collaboration with input and other CSOs. You've brought many different types of opportunities, but also challenges. You talked about the funding, and it's quite clear how the lack of funding can impact on the service delivery on the ground. Now, we will come back to some of those challenges later on because we have additional questions about that. However, I'd now like to turn to Professor Baldacchino to hear a little bit about the practical implications of guidance such as this one in the clinical practice. How can such a guidance be put into good use in a clinical practice, and other reflections you would like to share as a clinician? Thank you, and a researcher professor.
Thank you, Anne and Janelle. It's always good that I talk at the end, following the experts that have already been mentioning some elements, which I agree completely with all the components. But first thing is that I think the document is timely. It's well done. In spite of the challenges that guidance like this can provide, but it's clear, as Katri said, it's clear. It is what it is. Using sound methodology, and I think it is one of those where it's clear what we need to do. And from my perspective, when I was asked to think about the implications of this document, I was looking from a macro and micro components. The macro elements is that from a European perspective, and I suppose this is a guidance document not just for European countries, but for other countries outside Europe, is the importance of moving on to not only expressing what the quality principles should be when it comes to injecting drug users, aspirational as they could be, but to ground them into proper standards, realistic pathways. And that includes not just people within the clinical environments, stakeholders, as Matt has been mentioning, important people, experts by experience, and others who are part of that journey of the individuals who are working with patients, clients, customers who might have comorbid conditions. But the reality is that individuals with substance use, injecting or not, are polydrug users. And again, I'm hinting here on this person-centered approach, where having infections is one of the many challenges that this population, including not only sort of physical medical conditions, but also social conditions, as again Matt and Katri mentioned, the stigma. But I think there's one element which is very medical. It is really excellent that the list of vaccines, the list of important medication has been evidenced, but it is important from a policy point of view that they are part of what we would call essential medicines. Part of my previous life is I worked with WHO in the Middle East, and you find that even though individuals need opioid use medication, only 10% of the countries actually provide those medications. So that's an important component, really, is that not only do we now provide as essential medicines methadone and buprenorphine, but as essential medicines, end products, we should provide harm reduction, toolkits, tools, and also vaccines. Yeah. So that's from a macro perspective. From a micro perspective, I think one of the few good elements of COVID was that from a clinical perspective, we don't talk about harm reduction. We don't talk about treatment. We don't talk about recovery. We talk of individuals who need help. And if that service needs to provide what traditionally has been known as harm reduction, then so be it. But the narrative has changed. And the narrative is about providing the right service at the right time with the right interventions. So we need to normalize this language here around this, because what I've read here is bread and butter for me as a clinician, and I'm sure it's bread and butter for Matt and Katri and other people around here. Or else if not, then we're missing something here very important. I think another implication, and this is about empowerment, another implication is that, we have the evidence here, but let's push the boat a little bit. I hate to use the word innovation. Let's put this boat a little bit. How can services, communities, be able to support for individuals to test, self-test for hepatitis C? When we know that we have the right treatment here, which is going to help support and minimize morbidity and even mortality. So I'm pushing the boat a little bit more, into thinking about empowerment, but also equally from a clinical staff perspective, inclusiveness. This is an opportunity for pharmacists and other prescribers and other clinicians to be part of this process, not necessarily being part of the addiction services framework, which I agree with you, Matt, can be very limited, very, dealing with minimal, not the majority of the population, but to empower pharmacists and nurses to be part of this process when it comes to reducing infections and catering for the right treatment at the right time. And that's usually the problem, is that, the current pathways that we have are very, very clunky and slow, and individuals cannot really sort of, when we're talking about situations, I think Katri mentioned complexity, is expect any individual to understand what actually the pathways are right now. So it's going back to the macro element that I mentioned. Thank you.
Thank you very much, Professor Baldacchino. I think I really like what you said, because you talked about the many principles of service provision, from inclusiveness to empowerment to quality control. In the updated guidance, there is actually a whole chapter about principles of service provision. So you really touched on many of those principles that are so important in when it comes to delivery of quality care for people who need it, and the right people who need this care and support. And you also mentioned about the social challenges, and I think the guidance also recognizes some of these the structural barriers to service provision or for people to be able to uptake services, and the homelessness, which appears to be on the increase in many countries. So very interesting perspectives from the clinical side. I will now turn to my co-chair, Janelle, who will pose the second question for our panelists today to reflect on.
Yes, thanks, Anne. And actually, the second question flows quite a bit from the responses to the first. So again, going back to the issue around resources, and Alexis had brought up the need to address violence. We have legal barriers, there's stigma and discrimination, but we also have some opportunities in terms of multi-sectoral collaboration. And in this regards, we'd like to ask the panelists again, one by one, the responses to the following question. And this time we'll begin with Matt. And the question now we have for you is, what are the main barriers and facilitators to implement evidence-based interventions for people who inject drugs? And Matt, will begin with you.
Yes, thank you. I think the challenge, I think, to start with, to repeat myself, is funding. I think both for harm reduction. I mean, we have a very restricted amount of funding available for harm reduction. That really makes it very challenging for drug services to reach people who inject drugs, because you can't just open a service and expect people to turn up to use it. Particularly the most marginalized members of our community need to be reached out to. We need to use innovation to engage people and take services to people. We've seen really pioneering work. For example, EuroMPOD is about to publish a new set of guidelines where we document the really amazing work of the Prolar drug user group in Norway and also GAT in Portugal, where they're really using community-led organizations to take Hep C testing and treatment out to people who use drugs. They're engaging people in the communities where people are using and then drawing them through into treatment, rather than expecting people to go through a very complex pathway of using multiple agencies. But actually, with the Prolar model, taking a bus out to open drug scenes, taking the whole process right through to the start of treatment, being done in a mobile bus, and then connecting people into the healthcare system, using peer workers to then support people so they can adhere with treatment. I think we too often talk about the barriers or the inabilities of people who inject drugs to engage in the system, rather than looking at why the system is so difficult to engage with. And I think that's where community models can be so effective. I was really disturbed today to hear our Swedish drug user group talking about the challenges of promoting hepatitis C testing with people on opiate agonist maintenance treatment. Now, in Sweden, where there's a very restrictive model of OAMT, we see people fearful to test. Why? Because if they ask for a test for hepatitis or HIV within OAMT, they are then acknowledging that they're actively using drugs, and then they will face greater restrictions to how they will be asked to pick up on a daily basis. They will then have to be supervised in their treatment. Now, this type of disconnected system is really concerning to me, and I think we need to find greater ways forward. I think the wider legal environment remains a critical barrier. Now, while we're being pursued by the police, while we're being seen as criminals within the system, it makes it very disconnected that on one hand we're being invited to engage within a public health response, and on the other hand we're being criminalized, tracked down. These two things jar with each other. What else? Yeah, and I think the other issue is the sort of political will. I mean, I'm very, Professor Alex Stevens from Kent University has written a very new, interesting book on drug policy, and he challenges this concept of evidence-based policy. And what he says is it's not about evidence-based, because if it was evidence-based policy, we would be doing drug law reform, we would be doing harm reduction, we'd be doing humane drug treatment. Why don't we? Well, no, we need to actually care about the population that is the subject of these guidelines. And the problem is, I think, with the rise of populism, people who use drugs are a very convenient population to scapegoat for politicians. And I'm mindful of Sam Friedman being on this call, who really helped us understand this concept of scapegoating, where a particular population is used by malign politicians to whip up negative sentiment against our community. And that again makes it very challenging to have a sensible conversation about how does society benefit from harm reduction, how does a society benefit from good quality drug treatment, and how do we start to move forward with new enhanced harm reduction like drug consumption rooms, like drug checking, and logically, how do we create an environment of decriminalization as a meaningful stepping stone to ending the ridiculous war on drugs that makes public health responses so difficult to implement.
Thank you, Matt. Now, Alex, I turn to you it's a difficult act to follow, but I turn to you regardless for your insights on what the main barriers and facilitators.
Thank you, Matt, because you set the scene for what I was going to say, actually. You're absolutely right, evidence-based policy. And then, what happens to this evidence? And nothing much really happens unless you have a very concerted effort by all stakeholders and with the right resources, financial and others. I've put here various facilitators to implementation, to implementation is actually about the implementation. Gone are the days when actually we hope that policy becomes practice, just like this, and especially when we're talking about complexity. I think the first thing, and I say we, is everyone, EMCDDA, policymakers, clinicians, community workers, advocates, is that we need to embrace complexity. I think in the past we used to use complexity as an excuse for not doing anything, and as a way of saying how expensive this is and we cannot understand it, so let's try to simplify it. And what tends to happen is you tend to polarize it, this notion of harm reduction treatment, but also you tend to polarize what is acceptable and not acceptable. And I'm really sorry, Matt, that in Sweden, people are actually doing, the thought process is about that polarization. Oh, you need to be drug-free before you even start your methadone. And, can you imagine then, a system which is sensitive to the needs of the individuals, especially when it comes to infections, all sorts of different types of infections with high rate of mortality. And we let that go because essentially there is a philosophy, a polarized philosophy going on. But I'm trying to be positive here. By embracing complexity, we can start thinking about equity implementation programs. Sounds really, really, sophisticated, but it isn't. It is an opportunity that if we have equity as core to the guidelines that, like this one that we have, then we're able to understand what the components are when we look at the reality. I call it the ecological validity, the reality out there. The reality out there is people don't come with tattoos on their forehead saying, oh, I have a drug problem and I have an infection. Actually, it is the responsibility of the clinical and other environments to ask the right questions. Sometimes we do not do that because we're either too busy, too tired, too burned out, or we don't even want to know what the answer is because then it becomes too complex. So through this equity implementation process, you can look at different types of syndemic activities going on. This is what we're talking about here, is the same population are having different types of issues that are of public health concern, but personally that are of individual concern. And we need to find a way that is explainable to the policymakers, to the commissioners and the other stakeholders who can understand what we're talking about here. The problem that I have, and I'm sure Matt and others have, is that we know what we're talking about at different levels. We have different types of experiences, but we're not very good in expressing that before we start to alienate the commissioners and etc. This, for me, is the guidance for me is an opportunity to explain to individuals how we can talk about multiple morbidities, how we can explain to them why they are hard to reach, how we can gather intelligent data, not because of the individuals, but because of the systems that need to change and be flexible and have a narrative that allows people to be part of this process. Thank you.
Great. Thank you, Alex. And now, Katri, I turn to your perspective on the same question again.
Yes, and I have to agree that it's good to be the last one because really, thank you, Matt and Alexander. It's good overview, and I'm not going to repeat some elements you mentioned already, but I had a similar thing in mind that when we talk about barriers for the people who inject drugs, then yes, with all these services mentioned in the guidance, we have to like keep in all the time in mind that the receiving end is people who inject drugs, who are actually one of the most vulnerable and stigmatized target group. So nothing is easy for them. I have been involved with many like practical things within the harm reduction services, and that I know that many of them have a language problem, and actually they don't orient in the general welfare or social system at all. So like it was said, the key answer for them is the community-based services, what we have to empower. They know the services, they are familiar with them, and they are used to going there. So, but the tricky point is that how to actually convince the decision makers that we have to like keep this kind of a parallel systems available, because they say that the services are existing and they can use them, but no, for this target group they are not existing actually, and really we have to like describe them, what kind of a social situation and what are their needs, and we have to really advocacy the people who inject drugs, the target group, to the decision makers to have this kind of parallel services. And of course, the linkage to care, it's always problematic, that it was said already here that mostly we need the physical guidance for the people actually to get them from point A to point B. And it's not easy also in that sense that, for example, in Estonia, social system and health system are, how to say, like different pillars. And it's quite difficult to move between the pillars, even for me sometimes. So if we talk about vulnerable groups, then it's quite impossible. And when we talk about drug treatment or care, mostly it's mixed with social and healthcare elements. So that is tricky. And for the last point, also the legal, what was also mentioned here, national legislation is the problem. When we talk about consumption rooms, then for sure we have to change the law, because the law says that any kind of drug use, especially in public places, is against the law. And also, even like if you think about testing and vaccination in harm reduction services, as I mentioned, that the community-based services should be like the key for the target group. Then most of our harm reduction services are NGO-based, and based on law, they are not allowed to offer health services. So how we can like integrate testing and vaccination in the services, what is actually really needed there if we have this kind of boundaries. So that would be it.
Great, thank you, Katri. Yeah, in some, I pulled several pieces of the points, and the things that stood out to me is that I think what I gather from your collective contributions, that really we need to start by caring about the population as a collective. We need to really, truly understand the challenges that are being faced, to include legal, such as what you've mentioned, Katri, about including health service provision within NGOs, what the needs of this group are, as well as changing the question. I liked how you phrased that, Matt, about why are they not engaging with services, but why are services so difficult to engage with? And I think the piece about complexity, about the need to embrace that, things are not getting simpler. We are getting more complex. So how to work with that versus trying to fight against it, and engage and empower community along the way. And then the other two pieces that stood out to me about equity being core to implementation moving forward, as well as finding a better way or an improved way to explain it to those who already don't know what we're already talking about, and trying to use the guidance itself as an opportunity to do this. And so with that, I'll pass it on back to Anne for the final question for Katri, Matt, and Alexander.
Thank you very much, Janelle. The final question relates again back to the challenges. However, since we've heard many challenges from all three of you, what I would like to do is to zoom in and ask you all reflect on what you consider as the topmost challenge. Because, of course, when financial resources are limited and there are global events that are taking place and the policymakers' attention is divided. So if you were to pick one challenge and convince a policymaker or somebody else you consider as critical to move in terms of moving forward, what would that be? And I will turn to Alex if he would like to reflect on the topmost priority from his perspective as a clinician.
Okay.
Of all the ones you brought to the table, all three of you.
Topmost, yeah. I think the challenge is we need to go back to basics. Might sound not very sophisticated. We need to go back to basics. Go back to basics around how we engage policymakers, how we engage with systems of care, how we engage with the people who are trying to access the system. Back to basics to what our roles and responsibilities are, and back to basics to what actually is our mission. You know, EMCDDA and others use the word mission. So for me is really not take anything for granted and reassess the situation, just the reality of where I work, where Matt worked, where other people work. But also ask ourselves, do we actually deliver? And that was purposely, and why I said, you know, I'm honored to serve our citizens. And I meant that. And even though, you know, I might be considered as a clinician, a professor, a psychiatrist, you know, the dark side of some people. We're not. We're all human beings, but we all need to reflect and reassess what we should be doing to make anything that we do person-centered, not even patient-centered. So back to basics. You're on mute.
Sorry, I clicked on it, but it didn't. I can't click. I really like what you said. We are all human beings. Going back to basics, I think it probably resonates to everybody on this webinar today. Katri, how about you? If you were to pick one challenge that you could change, what would it be and why? How can we move forward?
I like the idea back to basic, but if I would choose one, maybe I would go another direction. I think that the future challenge would be how we advocate the new harm reduction services to the wider community and also to the decision makers. And it also relates to the stigma reduction, because I have a feeling that it would be nice if we have some, for example, even best practice guidance, how in the future we should actually deal with this kind of hostile and resistance situation that we have towards services and, of course, towards the people who inject drugs also. Because I have a feeling that in Estonia, for example, sometimes the public resistance is the main obstacle to actually develop new services for the people who inject drugs. And I think I picked it because of, I think that in times of limited resources, this becomes even more important, how we actually advocate the services and fight for our target groups. Thank you.
Thank you, Katri. And I'm quite sure that Matt, public resistance probably resonates with you and input members. I'm sure it's something that you are often faced with. But what are your thoughts about what would you like to see changed and why? What challenge you think of all the challenges you brought to the table you think is of utmost importance if we are to move forward in scaling up of these life-saving services?
Yeah, look, I think the real challenge that we've got to address is the sort of nature of changing drug trends. I think I'm very proud of the work that I've been doing with UNODC, UNAIDS and WHO promoting their stimulant guidelines around the world and championing the response to people who use stimulants around the world. And I think that's a key issue that we haven't always addressed effectively. And also, I'm particularly concerned by the sort of beginning of drug-related deaths associated with synthetic opioids. We've seen 35 deaths recently in the UK, 30 people dying in Birmingham, 5 people dying in Bristol. Now, I met some of the drug users in Bristol because we're doing a stimulant project there. Now, one peer told me that he saw 3 people go into a local park together. They were carrying naloxone with them, but because they injected all at the same time, all 3 of them died. And this is the nitrazines contaminating the heroin supply. Dublin has seen 35 deaths all in 1 week. Now, is this but the beginning of a US Canadian style synthetic opioid contamination? We're seeing the Taliban doing what the world has asked, which is destroying the heroin supply. Now, if we're seeing 95% of the last year's crop destroyed, we have 85% of our heroin in Europe comes from Afghanistan. No, where is that? The criminal gangs are not just going to stop their income. I really fear that we're going to see synthetic opioids contaminating the heroin supply, poisoning the heroin supply, and we're just not ready to deal with it. Now, that means we've got to think about drug consumption rooms. It means we've got to think about safe supply. It means we've got to think about drug checking. We have to be bold if we're going to be facing this type of epidemic. When I see the trauma being faced by my peers in North America, I'm horrified at the thought that we could be about to face a similar poisoned heroin supply in Europe. And so I really think enhanced heroin supply isn't just aspirational, it's absolutely essential, and we have to be prepared. We can't wait for this to happen. We have to be ready for it to happen.
Thanks very much, Matt. I'm glad you brought up the emerging challenge of synthetic opioids. And I'm going to post in the chat a link to an EMCDDA, a very recent spotlight on fentanyls and other new opioid situation in Europe, because it might be of interest to many of the participants. Yes, Sam, yes, I said explosive in the chat. Yes, we are very concerned, and EMCDDA is definitely looking at this issue of changing trends, emerging use of synthetic opioids and the related drug-related deaths. So thanks, Matt, for highlighting this challenge. And also the stimulant injecting. Many of the HIV outbreaks, for example, that have taken place in many EU countries are because of stimulant injecting. So we also have resources on our institutional website, and also the guidance includes content that was not necessarily there in the first edition of the guidance that was published in 2011. So all of this is now being addressed, and that's why we all agree that the guidance needed to be updated, because there are changes in the patterns of drug use in many countries. And I wanted to mention that while the focus of the guidance is on the European Union and EEA countries, EMCDDA also works with countries in the European Neighbourhood Policy area. And we actually had members from representation from Georgia and Ukraine in the expert panel that was established. And we definitely intend to for those countries in the European neighborhood also to make good use of this guidance. However, now I think we've addressed all our three questions to the three panelists, and we are now moving forward to the question and answer session. So once again, I'd like to remind all the participants to please use the Q&A button at the lower part of the screen. You see the Q&A to post your questions, and Janelle will take the first question and hand it over to a panelist. Over to you, Janelle.
Yeah, so I actually have two questions in combination, both come from Jordan, and so I'll read them together because they relate. So she states that in Ireland, it is impossible to carry out our national strategy without the appropriate funding and resources. How can we selectively lobby and push for more? And then the second part is, as researchers, we always say early intervention and prevention. With such limited finances and resources, is there any thought to improve prevention? It seems that we are all fighting fires and prevention is forgotten. What about a fundamental investment in our young people? And for this, Matt, I think I'd like you could start us off.
Yeah, look, I mentioned Professor Alex Stevens' work from Kent University, and I think this really starts to speak about evidence is really important, and professionally, we all need to respond with the evidence. But actually, that's not what changes politicians' minds. It's not what changes the general population's minds. No, it is actually a much more emotional response. It's much more understanding feelings. And if those feelings come from dirty, scummy drug users, dirty junkies, how do we get them out of our society? No, that's a very difficult position then to argue for funding. If we can start to humanize people who use drugs, and I think that is best done by us as a community stepping up. It's why, for example, I went from being a professional head of drug treatment services and decided to come out publicly about my drug use, because I realized in the late 1990s that this wasn't just a public health struggle, it's a political struggle. The fight for human rights is critical to people and politicians saying, we are invested in supporting this group of our very marginalized citizens to have access to health, to have access to the transformation that humane drug treatment can offer in people's lives, and that can also benefit our society. When people are drawn back in, that benefits everyone. When society is more integrated and benefits, everybody benefits from that. I think the polarization we've seen in the recent period, where we start to demonize and scapegoat particular populations, it's really, really unhealthy for our society, and it's how we embrace each other. And I think that comes from understanding. And I think that requires people who use drugs to be brave enough to stand up and say, this is us, this is who we are. And I think more people need to be willing to take that risk and to start to change the narrative about who we are as people who use drugs.
Matt, Katri, Alexander, would you like to add anything to that?
I think that was a perfect recap of the situation. Really, my thoughts were exactly that we have to actually humanize the target group, and we have to listen to them and actually learn to very simple words speak to the decision makers, so that they understand what actually is the situation, and always aiming the bigger goal what we have, prevention and control of infectious diseases. And we not talk about only among people who inject drugs, but this is for the wider community.
Just one note, it's we talk about us and them, and at the end of the day is, I think, Matt, you touched upon it. This is about human rights. That's it. There's no rocket science to this. This is about human rights. And from my clinical perspective, one thing, as you know, Scotland is not doing very well when it comes to drug deaths, and we're dreading the fact of that being compounded by synthetic opioids, is the quality principle that the Scottish government has agreed to embrace. And they are human rights strength-based approaches. You know, one has, we have a duty to provide the best care at the best place with the best, you know, trained individuals. It's very simple, straightforward, and can be replicated in other countries. And just as a reminder, we as European countries, the collective we, have signed all the mandates around human rights, or signed all the mandates around providing care for everyone access. So, you know, policymakers might decide to ignore that, but we need to remind policymakers that they have an obligation. It is not about the money. It is about the mindset. And if you have a mindset that is ready to grow, to approach things differently, then we can move on with this. But at the end of the day, it's very simple human rights issues here.
Thank you. Okay, we are moving on to the next question that we have in the chat, and this is from a colleague based in Lahore, Pakistan, who mentions that prevalence of HIV is very high among people who inject drugs, and which international organizations can collaborate and support. So basically, to mention the guidance that we have addressed today, it's very much a European guidance, but of course we hope that it is relevant to also countries outside the European Union. And in Pakistan, like many other countries in the Asia region, there is a UN family working and supporting the governments, such as the National AIDS Control Program in Pakistan. So there are many international organizations, but certainly the UN family is there, the Global Fund is supporting, and many other partners that can be turned to. And we hope that the guidance will also be looked into in your country, Pakistan. Now back to Janelle for the next question.
Yes, and this one I think we'll direct predominantly to Alexander. There's a question about, could you be more specific with the term equity? What do you imply? And could you expand on your statement?
Okay, equity is more than diversity. Equity is about approaching the issue at all levels of what would make an individual feel, not just feel less than other individuals. Equitable, sometimes we talk about being equal to each other. Equity is more than that. So it's the summation of all the elements that would make one individual, even though they might look different, they might feel different, they might do things differently, as part of mainstream society. So it encapsulates, all the components around gender, sex, and everything else that you could think about. It's quite a challenge, actually, because it's a society that is based around power, for example, based around us and them, and based around, again, going back to the polarization. So it's again I'm going back to what Matt, perhaps I'll introduce this notion of relationship capital. Is that when we look at equity and trying to implement things using this implementation science, using syndemics or normalization theories, etc., is that we need to understand that we are part of a collective. We're part of something bigger, and we need to understand within ourselves as well with our peers and with our community that we are part of something bigger. And that's when you start thinking about equity.
Thank you. Katri, Matt?
Shall we move on to the next? We have one more question in the Q&A, and this is from Sam Friedman from the US. And what he has said is that from the US perspective, but also he thinks it's wider. His question is, why does the social, political, economic system keep on generating so many people who find the risks of using drugs so necessary in their or for their lives? And I was wondering, Matt, if you would like to, can you see the question in the Q&A, Matt? Would you like to reflect on that? It is coming from the US perspective, but you've also mentioned there are some similar challenges that might be coming up in European region. So yeah, please.
I think Alex's point about complexity is something that really resonates with me. I really find it very difficult when people come up with universal theories of drug use and present the answer to why people use drugs. I think drug use is incredibly complex. I think it's why complexity theory is such a useful way of understanding drug use. So I think there are multiple reasons. I mean, I think people are looking to have pleasure in their lives. People want to have enjoyment, and drugs are very pleasurable to take. When you understand how to take drugs effectively, they can be very enjoyable to use. I mean, I was part of the acid house generation, and dancing and partying on ecstasy was a very wonderful thing to do. It was how it grows your heart. It helps you make human connection, which as empathogens is very important to us all. There's also another factor, which is if we look at where drug use is most destructive in our society, it's often in those parts of the world where the industrial base has been really destroyed. Now, if you're looking at why is Scotland facing so many problems, or the north of England facing so many problems, it's because industry has been ripped out of working class communities that have left people really with a lack of purpose, a lack of sense of who they are in the world. And I think then people's use of drugs in those societies changes its form, it changes its shape. It becomes about trying to manage that lack of belonging, that lack of purpose, that lack of connection. And then also there's lots of people who are experiencing trauma and have had trauma in their lives, and then they look to use drugs to manage or mask that trauma. I think that can be a feature among women who use drugs, particularly why, not exclusively, but there's a particular narrative around people who've had experiences of childhood sexual abuse or been raped, or that becomes a part of managing their drug use. It's not to say that drug use is wrong in that circumstance. I think we need to understand, why are people trying to manage their pain? I remember a wonderful Dutch psychiatrist saying to me, why are we so worried about helping people manage this pain in their lives? What is it that stops us feeling that's okay when people are dealing with such deep trauma in their lives? So I don't think it's one thing. I think it's multiple things. And I think part of the challenges of talking to politicians and the public is how we start to have a conversation about something which is so complex and so multifaceted that populism is attractive because it comes up with simple solutions. And coming from the UK, we can see the catastrophic outcomes sometimes of following through on really simplistic solutions, which in the telling sound great, but in the practice are catastrophic. So complexity, but I think it's how we manage that complexity and communicate it is the real challenge.
Thanks very much, Matt. I do see one question coming from Serbia. It's very general. The question is simply in the chat. What do you think about Serbia? But I'm not sure we can answer, any panelist can answer such a broad question unless you please make it more specific and put it into the Q&A. We'll wait for a moment. Yes, let's give just a moment if the colleague from Serbia wants to put the question in the chat, in the Q&A box rather than the chat. We also have a poll at the end of every webinar. There is EMCDDA launches a quick online poll that will take probably a minute. So we want to allow for that. I don't think the question about Serbia is coming. So I think without further ado, I would like to thank, as we're moving towards the closure, I would like to thank wholeheartedly all our three panelists today. I think it's been very inspiring, enlightening, and motivating discussion, informal conversation, as we like to have. It's been thought-provoking. I think obviously many challenges, but also many opportunities for moving forward. And I also wanted to mention a couple of updates on behalf of both my colleague Janelle and I. What is ECDC and EMCDDA planning next in relation to this guidance? So first of all, a policy brief has been developed by ECDC and EMCDDA, and this joint policy brief basically summarizes the updated guidance, which is a longer document. The policy brief is a shorter document with a main target audience of policymakers who might not have time to go through the detailed document. So the policy brief will be coming out very soon. Secondly, the guidance will be translated into all European Union languages, and we are also considering translation into select languages of the European neighborhood policy area, such as Ukrainian and Georgian. We will see if we can also consider Arabic. And thirdly, EMCDDA is also in the process of developing e-learning materials, which will be eventually available on our institutional e-learning platform called Plato. Plato currently hosts e-learning materials about evidence-based drug prevention. Please keep an eye on our institutional website for updates about e-learning materials in the area of prevention and control of infectious diseases among people who inject drugs. So I think these are the three updates, or what we are planning to do next. I would like to ask Janelle if she would like to add anything, or whether we hand over to... Yes, please.
I was just going to kind of summarize my takeaways here at the end when it comes to implementing the guidance. And that's that it's important to acknowledge and manage the complexity, but ultimately it's really simple, and it requires us working together, both across organizations and across different levels, whether it's local, regional, or national. And ultimately, we're all human. And it's not about us or them, and this is drawing on what the panelists had brought up earlier, but we are all a part of a collective and something bigger. And I think that this is a very key piece to us moving forward with implementation of it. And with Anne, pass it back to you.
Thank you, Janelle, for your nice concluding remarks. So thank you, panelists, and thank you to my co-chair. Thank you to all the participants who joined us. I don't know how many in the end, Ale, do we know?
Yeah, no, it was really successful. We peaked almost at 200, and we are still having 133 online. So
excellent.
Really
so
excellent.
I think there is clearly a lot of interest, a lot of support for this area. So now over to you, Ale, if you can just run through the poll. Yeah. How does it work? Thank you very much, everyone.